giant of limitless power at man's command. And where was it science found that giant? In the atom, a particle so infinitely small that it takes over 100 billion atoms to make up the head of a pin.
This is Out of the Basement, a podcast dedicated to radiation medicine.
Right, I am Dr. Jason Becta, and this is Out of the Basement, a podcast dedicated to practical radiation medicine, or at least that's, again, always the stated goal. Turns into these long Ken Burns documentaries, but whatever, we're going to get back to our roots. By roots, I mean thing I had in my brain, but didn't actually, I don't feel like I actually did. So shorter, practical, quick hit. Was going to call these things RVU school, but then somebody pointed out RVU-U would be funnier. So I'm going to go with RVU-U. But basically, all the things that we don't get tested on board exams, but matter for literally every day, every hour of every day that I and most of us had to learn the hard way. So trying to shortcut that for the rest of us. And I figured I'd start with my favorite. So yeah, RVU-U, favorite thing to talk about, which is quote unquote on-beam, the on-beam metric. What is that? So when we're residents, we hear this all the time. This is like the favorite sort of American rad-onc metric. And I had no idea what that was. No one, well, I mean, on-beam means when the linear accelerator or LINAC, how many patients are treated per day per linear accelerator on beam. And obviously that's literally what it is, but everyone kind of talked about it as a measure of a clinic's busyness, of what was going on. It meant nothing to me. No idea. And arguably, many, many years later, still means nothing to me. So when you are evaluating a potential job or talking about services or how busy or how not busy a certain service is, it is meant as a shorthand way to communicate with each other, simply because it's very difficult. What we do is very different from most of medicine. And in sort of office-based, the quote-unquote cognitive versus procedural sort of specialties. So for a family medicine physician or type of doctor that mostly does outpatient, what's called E&M or evaluation management visits, those are measured by appointments per day. So if somebody's seeing 30 patients per day or 4 or 5 patients per hour, that it kind of makes sense. Is 60 minutes in an hour, obviously, hard-hitting facts here. And if you're kind of seeing 4 or 5 patients per hour, that kind of communicates. Everyone can kind of understand that, but it doesn't really work for radiation oncology because the majority of the E&M component, the clinic visit component, is actually the least sort of intense part of our job. It's everything else. And so on beam is a way to give radiation oncology sort of a visits per hour sort of deal, except it's kind of it probably was always hot garbage, much more hot garbage now, but maybe less so back in the day. So in the 80s, 90s, probably before, there was basically one choice. It was to radiate or not to irradiate, right? And external beam radiation, there was a sort of one-trick pony. That's oversimplification, but they didn't have VMAT back in 1991. So you could kind of actually have a more accurate understanding or generalization of on beam. So in 1991, if somebody said I have 30 on beam, or somebody said they had 50 on beam, because you talk to those guys and gals, mostly guys, let's be honest, who were practicing back in the 80s and 90s, and people out there 50, 60, 70 on beam, but sort of the process was very different than it is today. And especially if you go, there's a paper I quote all the time from Canada, I think it's Alberta, published in 2021, I believe, and they looked at the workload over their clinics for the last 10 years, basically trying to look at the resource intensiveness of modern techniques of VMAT, SBRT, those things. And so over that 10-year period, there was like a 40% increase in patient volume, but 150% increase in work as measured by time and output and those sorts of things. So most of our things have gotten more complex. So on beam, it doesn't take any of that into account. And if you have 20 on beam, what does that mean? That means very different things if it's 20 on beam and you're a breast attending, or 20 on beam and you're a generalist in a academic mothership, or you have 20 on beam and you're a generalist as a solo rural community doc. Those are all very different things, but it's all 20. And the trick of it is the administrators don't really care about the nuances of that. And then that's not fair. They don't care because they don't know, because most people don't know. And even if in residency, when you're kind of being trained by folks who sometimes went right from academic residencies into academic faculty positions and have never seen anything beyond what, especially if they're practicing in the same institution they trained, haven't really seen much else, it's really hard to kind of communicate these things. So for residents or for people considering job switches and kind of haven't seen other ways things work, you have to kind of look at everything else. So 20 on beam. So the question number one is what 20 on beam of what patient mix? And usually what that means is it generalist, meaning 20 of everything, or specialist, or focused on one or two disease sites? And because the workload required on the physician end is arguably different for, not to keep picking on breast here, but the workload of putting 20 3D breast patients on beam is different than putting 20 VMAT head neck on beam. So that's number one, is if you hear this metric, the question is, what's the mix for that? We're just assuming like for a job you're evaluating. Number two is what modalities are being used for those 20 on beam. So again, this really depends on you don't really see this in the large academic training centers. In community settings or smaller satellites or whatnot, somebody might only have a single linear accelerator, and that linear accelerator might have things that you've seen before. So if there's an older like Clinac model, like a 2100 or whatnot, there might not be like a 6-degree freedom couch, or there are clinics out there that are still doing like compensator-based IMRT. Or so you could say, oh, I have 20 on beam in a general sort of patient mix. But then if it's a true beam versus a 2100 or a trilogy that was installed in 2011, that might kind of be two different things, and those workloads are different. So what is the patient mix? What is the modality mix? And really the big one too that I don't see talked a lot about, that really kind of affects my day-to-day in my current role. So in my current role, I solo staff a rural single LINAC clinic, and I can tell you my on-beam number, you can point me to somebody who is in a 4 LINAC like urban sort of setting, and we could have the same number on beam, but our experiences are very different, even if those patients and the modalities are very different. So it's the support staff around you. And again, this is just kind of as a physician, sort of, if you're using this metric to kind of analyze how busy you're going to be. So what is the process of care? How is the patient navigated through a course of care with you? And if you have excellent support staff, secretarial front desk staff who are kind of obtaining outside records, building the charts in a comprehensive and cohesive way. If when the patient comes in, if the intake paperwork is being done appropriately, when they're being loaded, if the nurses or assistants or whoever's doing it is kind of med-recking, doing sort of an intake or not, then on the back end, how are SIMs scheduled, where are SIMs, like my department doesn't have a dedicated CT SIM, for example. It's we use the one in radiology. What is the dosimetry staff? What is the physics staff? How many therapists? What is the treatment hours? All these things really sort of change, because if you are having 20 on beam, but for staffing reasons, so I know that there's kind of several places are having issues with therapist availability or therapist staffing. So if you can only have treatment hours that are 6 hours in a day, and you have 20 on beams, it's going to look and feel different than if you have 8 or 9 or 10 hours. And so that's kind of from the thinking about this from whenever I talk about these things, I'm talking to myself in the past. So these are the things that I didn't know about when I was a resident, because it's just hard you don't see that, like you're in a giant center. So when somebody would talk about on beam, and so because I get this question a lot from residents looking at their first jobs, and when I ask them that, just don't pretend. So by the way, too, I'm always, if anyone wants to reach out to me or whatever, when you talk to people who have graduated, don't pretend, like, because then that's not really helping you. Like if somebody's like, oh, well, do you know what on beam is, or somebody's telling you on beam and they're clearly trying to communicate like how busy or not a place is, and you don't know what that means, don't pretend. Just say, like, can you kind of drill down on that? So yeah, patient mix, patient modality mix, support staff, those are all the big things. And then on the back end, sort of a daily battle we still all have is talking with admin and trying to get them to understand. So currently, in the era of hypofrac, there was for many years, the on-beam metric sort of worked much better when you really only had kind of one or two modalities, like everything was 3D or not, or 2D, whatever. So when kind of everything was like the same treatment style and all the reimbursement was the same and everything was conventional, meaning the 1.8 or 2 gray fractions, on-beam had more value then. Now with hypofrac or the 5 fraction regimens or SBRT, but more complex treatments, on-beam pretty universally, I think for a lot of places, if you look at it from and that 2018 shift. So 2018 was when the breast and prostate hypofrac guidelines came out. I would say many clinics that have a general mix would see like a 20 or 30% drop in their on-beam. Now, depending on how savvy your clinic is or whatnot, that might be all admin understands. So they'll just see like, well, RadOnc is down. They're only 20, 30% of their historical volume. Well, the follow-up questions would be, what is the actual revenue generated, or what is the reimbursement and collections and whatnot? Because oftentimes, depending on who's doing the coding, billing, the modality mix, if you're doing hypofrac breast, but on the back end you picked up a ton of SBRT from oligomets or early stage lung cancer, SBRT reimburses a lot higher. So there are many times when the on-beam metric is down, sometimes down a lot, 20 or 30%, but the reimbursement or revenue is kind of similar, even increase compared to historical. But, you would think that people would pick up on that. And by people, I mean like admin or whatnot. You would think that they would pick up on that, but they don't. Like, don't assume that people are just going to know to do that. Like, because they're going to see that red number. When you look at those kind of fiscal reports, there's just going to be a glaring red number that people are going to zone in on. Unless you get savvy folks, they're not going to just say, whoa, look, well, that number's down, reimbursement's the same. Somehow it misses out. So the metric I prefer, and this is also good. So when you're trying to gauge the busyness of a clinic, somebody's communicating to you as on beam, I would try to find out, if you can, new starts, how many new patients are put on beam per year, or how many new courses, because sometimes you have repeat patients. That these days is, I've talked and debated a lot about this. It's really hard to know, and this is true of any field, any industry. It doesn't matter always what metrics matter. Most of the ones we don't. Humans are lazy. We track things that we can track easily, not because they're the best. And so when the debate of it's all the things we do are very intangible. Like, how do you even quantify work or busyness? Or it's very difficult. So the one I lean towards is new starts, because I'm a solo generalist, right? So to me, I know there's going to be a range, but if you tell me in this year I'm going to have 300 new starts, but next year I'm going to have 275, and then the following year I'm going to have 350, I kind of have a good guess as to what that looks or feels like based on everything else. That's very hard to just get a feel for, and the way I track that is through the billing code 77263, which is complex treatment planning, which is what I drop with the SIM, but that's a whole other thing. So that's just kind of how I would think about on-beam, is that there is some utility in that we still talk about it, but it really depends on many things. When you're talking with folks about it, is just be honest that if you don't know, and don't pretend like you don't know. But, my 20 on beam might be very different than the guy next door's 20 on beam. And I think it would behoove many of us to kind of work on moving admin for budgeting, for those of us who have that input or responsibility, to away from that on-beam metric and into something like New Start or something else. But all right, so RVU-U, short, quick hit. I'm at like the 15-minute mark. I got to stop rambling. New Year's resolution, stop rambling. I don't think I'm going to get there, but I'm going to try. Stated goal. So Out of the Basements, Photon Media, be there with us for the future. All right, back to out.
This has been a Photon Media production. Don't forget to like and subscribe on whatever platform you use to listen to us. Be well and beam on.